was diagnosed with right breast invasive ductal carcinoma in the last quarter of 2005 when she was only 25 years. She has no medical problem and is on regular menstruation. She has 11 years old son with her first pregnancy at 29 years and had a strong family history of ovarian and fallopian tube cancer. Elder sister was diagnosed with ovarian cancer in 2010 and died in 2015, and mother diagnosed with fallopian tube cancer in 2012 and died in 2016. Patient felt a small lump in upper area of 2005. Ultrasound revealed single 2.7 centimeter lesion in right breast with no axillary lymphadenopathy. Fine needle aspiration of the breast lump was positive for duct cell carcinoma. So patient underwent lumpectomy with axillary clearance up to level 2. Final pathologic staging was T2 and 0 MX. The tumor was ER/PR negative and HER2 positive by immunohistochemistry. So patient received 4 cycles of adjuvant chemotherapy with doxorubicin and cyclophosphamide, followed by external beam radiotherapy to the whole breast and supraclavicular area, including electron boost to the tumor bed. Then she was given remaining 4 cycles of chemotherapy with paclitaxel and did not receive any HER2 target therapy. The whole treatment completed during third quarter of 2006. She was on regular follow-up and reasonably well. In 2009, she delivered a healthy male baby with contralateral left breast lump in axillary tail during second quarter. The ultrasound findings was a hypoechoic mass lesion of about 2.8 centimeter into 2.2 centimeter. Fine needle aspiration of breast lump was appendectomy with axillary clearance up to level 3 was done. Initiated invasive ductal carcinoma with 9 axillary radiological staging was T2 and 2 MX. This time the tumor was triple negative by immunohistochemistry. No distant metastasis was detected by PET-CT scan and bone scan. Patient received 6 cycles of adjuvant chemotherapy with docetaxel and carboplatin, followed by locoregional radiotherapy to the whole breast and supraclavicular area, including electron boost to tumor bed. The treatment completed during last quarter of 2014. She was on regular follow-up and reasonably well. In 2017, the genetic mutation test was done and positive for BRCA1 mutation. In 2020, patient again noticed a lump in inner and lower quadrant of right breast during second quarter. Lesion at 5 o'clock position in right breast. Fine needle aspiration of breast lump was positive for duct cell carcinoma. So right-sided simple mastectomy. On histopathological examination, it was a moderately differentiated invasive ductal carcinoma with free margin. No lymph nodes formed during examination. Pathological staging was T1 NX MX. This time the tumor is ER/PR positive and HER2 negative. No distant metastasis detected by CT scan and bone scan. Now patient is 125 milligram by mouth daily for 21 days, followed by 7-day rest. Letrozole 2.5 milligram by mouth daily with ovarian suppression by injection goserelin 3.6 milligram subcutaneously 4 weekly. Now the question: how long the ongoing treatment should be continued? That is palbociclib, letrozole, and goserelin. Can PARP inhibitor like olaparib be added with ongoing treatment as combination regimen? Is it mandatory the multi-genetic testing and counseling for her son? What is the fate of this patient? Is there any option as because BRCA mutation is associated with high risk of ovarian? What is hereditary and familial breast cancer? When BRCA test is indicated? Thank you very much for watching.
Thank you, Dr. Astefchar Hussain. Now the house is open for panel discussion. Don Dizon, sir, you want to start?
Happy to. So it's a very complicated case, but for young women with breast cancer, always a very difficult diagnosis. You know, she was diagnosed in 2005. I was just looking to see when the phase 3 clinical trial of adjuvant Herceptin had reported, and that wasn't until 2011. Just goes to show you how quickly treatments have changed and how our approach to HER2 positive breast cancer has shifted. It's very interesting that she has not developed any metastatic disease, but continues to present with primaries within the breast. Obviously, if she presented today with a T2N0, HER2 positive breast cancer, we would have given her chemotherapy plus trastuzumab. There's even data with the APT trial that she could have just done single agent paclitaxel with trastuzumab with a T2 node negative breast cancer. But she did very well until, for 9 years, and then had a triple negative breast cancer, which again was treated with curative intent as I would have. It's because you cannot use an anthracycline. The other choice I would have considered possibly would have been docetaxel cytoxin or cyclophosphamide or the TC regimen. But given she was triple negative, some of us are using carboplatin in that routine, although it's not a recommended strategy yet in the adjuvant context. But again, she did very well until this year when she underwent a simple mastectomy for a right breast hormone positive breast cancer, which I see that you're treating with palbociclib and an AI. I'll just bring you some note here of the PALACE clinical trial that was presented in Europe this year that looked at adjuvant palbociclib, and it was a negative trial. So at least in that one trial, it doesn't seem like there's a survival advantage to using adjuvant palbociclib. We're trying to figure out why, and it certainly hasn't closed the door on that concept. But for now, I'm not sure it makes sense to commit her to an adjuvant palbociclib and letrozole regimen at this context. She is now 15 years. She's about 40. So I think ovarian suppression and an AI is critical. We now know, if she had presented at age 25 with all of this disease, despite it being ER/PR negative, right, we all probably would have put her on ovarian function suppression and an AI today if she presented at the age of 25 as she had. Granted, the data we understand with ovarian function suppression was really in the hormone positive breast cancer context, but she would have been at high risk. Again, I think the remarkable thing about the biology here is she was presenting with 3 different breast cancers and has not developed metastatic disease. So every step of the way, the chances of a cure of that breast cancer remains. And I would not treat her on a paradigm for metastatic breast cancer. Now, the question that's really interesting here is that she had this family history that really didn't present itself for a decade after she was diagnosed with breast cancer, at least. If I remember correctly, her sister had died at 2015, and then the mom in 2016, both of an ovarian cancer. The question is, was there a clue back in 2005 that she had a family history predisposition for breast or ovarian cancer? And certainly, as you caught up to all of this, by the time her mom and her sister had died of the cancer, she already had 2 breast cancers. I would love to hear from your radiation oncologist regarding the role of re-irradiation and all of that in her history, because that typically will define, right, whether or not you can do lumpectomy versus mastectomy. But knowing she has a BRCA1 mutation now is important for her son. Yes, he should be tested. He has a 50% chance of developing that. Puts him at risk for male breast cancer, pancreatic cancer as well, and prostate cancer. And certainly, if and when he marries, there's a potential of that gene passing down as well. As important, her sister's children, her brothers and sisters also all need to be tested now for the same BRCA1 mutation. So this is not a place where we do complete panel testing because we know there's a mutation in her and she has breast cancer. So you can actually just test for that mutation in the entire family, but the entire family needs to be tested. This is going to be an opportunity to prevent cancer in affected individuals. And then I think the third question was about PARP inhibitors. There's a really interesting study that was done at MD Anderson looking at the PARP inhibitor talazoparib, which has approval in the United States for breast cancer. And instead of using it in the metastatic context, Jennifer Litton used it in the neoadjuvant context. So women with a known BRCA1 mutation with a new breast cancer were given talazoparib alone, no chemo, for 8 weeks. And what she saw was a pretty significant pathologic complete response to talazoparib in the neoadjuvant setting. And as this trial is progressing, if you have that great response, you have the opportunity never to see chemo, that all your treatment will be with a PARP inhibitor. But that is highly investigational. We are not using it in the adjuvant setting. We are limiting it to the point of metastatic breast cancer. And I think for her, it would not apply right now.
Thanks, Dr. Astefchar, for his nice case presentation. Actually, young breast cancer patient is always has a bad prognosis, but due to the improvement of the screening, diagnostic facilities, pathological facilities, surgical approach, radiation techniques, chemotherapies, targeted therapies, both HER2 and hormonal therapies, now the patient nowadays survive a long time. This is the case. This case started in 2005, now 2020, she is alive. In this case, I am agree with Dr. Astefchar to prescribe her the palbociclib, letrozole, and Zoladex. So, how long the drugs will continue? From my opinion, from my side, regarding the letrozole, it may be continue 5 to 10 years with definitely using the bone targeted therapy, zoledonic acid, 6 monthly. Regarding the palbociclib, I don't know how much it will continue. In the metastatic settings, it will continue till the patient has the tolerability. It may be PARP inhibitor may be given after that the palbociclib and also letrozole if there is any progression of a disease. Regarding the BRCA test for son, definitely BRCA for ovarian and breast cancer, there is a tendency to their families to BRCA positivity. So BRCA test should be done.